everybody. In this video, we're going to talk about the low back pain and the approaches of physical therapy to low back pain. It's very important to understand that if the low back pain is an acute injury or the low back pain is coming from a chronic, meaning if it's the new type of injury to the low back or if it's something that lingers for a few months or a few years, that patient struggles with the low back pain. In an outpatient setting, as a physical therapist, what we do, we evaluate to understand the root cause of the back pain. Meaning, we have evaluation tools such as orthopedic testing, neurological testing, which includes dermatomal check, myotomal check, and the DTRs, which stands for deep tendon reflex. And we get a lot of information of the results of those tests, deciding if the nerves in the low back are involved or patient has any neurological symptoms, versus if the pain it's only mechanical, meaning it involves more like facets or any type of movement restriction with the patient that causes the low back pain. So that's the biggest thing in physical therapy, understanding the root cause of a low back pain in order to find a plan of care or a better plan of care for the patients to overcome the pain. As a physical therapist, you have to understand body movement, mechanic movement, physics of movements, because low back pain may have involvement of a SI joint, involvement of the pelvis, involvement of the hip, which the pain may radiate to the low back pain if the issue is coming from those other areas that I mentioned. Understanding through evaluation, a very detailed evaluations with those patients is important, which we call a differential diagnosis. If patient comes in with low back pain, I need to understand that the symptoms that patient gives you and the history will kind of like design my differential list for the patient, which helps the doctor to detect the issue closely. I don't want to get far from low back pain since it's the main cause for this podcast. Evaluating of a low back pain involves a few special tests in the office. If you do have neurological symptoms with it, that's when you need to start co-managing. You may want to get the neurologist involved, depending how severe the patient's symptoms are. Usually with like a disc herniation in the low back that adds tension to the nerve, patients will complain of a radicular pain, such as paresthesia, numbness, burning, tingling, sharp shooting pain, down to that dermatomal pattern, meaning pain or sharpness of the pain or the numbness, burning, tingling will go all the way to the big toe, to the calf, behind the knee, in the hamstring area, in the buttock area, in the glutes. These are all possible reasons for radicular symptoms that might be due to compression of a disc. I have a model with me right here. I'm going to show you guys what exactly the disc bulge or the disc herniation is. So we all have a disc between our vertebrae in full spine. They're a little more sensitive in the low back due to the mechanical of a trauma that might happen to the patient, and the disc starts bulging. This is an example or a picture of a disc bulge. This is like a normal disc. This is a disc bulge. If you look a little bit closely right here in this picture, we do have, in this model, we do have nerves, which exits from the IVF, which is known as intervertebral foramen, which is this hole right here. So when those nerves get under pressure by a disc like that, I think this is the better side, by a disc like that, it's going to cause a lot of symptoms shooting down the leg, which we'll call this radiculopathy, like a lumbar radiculopathy or discogenic radiculopathy with radicular symptoms. Sometimes the disc bulges, but it's very small that does not touch the nerve. With patients in this regard, they usually have low back pain that does not travel to the lower extremity, like toes, ankle, calf, knee, hamstrings, or area like that. Again, the evaluations utilizing the special test will help the doctor to decide if patient has radiculopathy or not. And also understanding the acute phase and chronic phase of the injury will also help the patients, also help the doctors to design a better plan of care. Just as a general, physical therapy has been helping a lot with those patients in order to get back to their normal activity of daily livings and pain. The biggest thing, the outcome of this podcast, I need you guys to understand is in physical therapy, we do help patients to get back to their ADLs. It stands for activity of the daily living, meaning if patient has back pain, they're unable to lift their kids anymore. They're unable to stand and wash dishes anymore. They're unable to bend over and tie their shoes. Like stuff like that, which we need to ask questions in our history taking to see what patients' goals are for physical therapy. Um, when you think about physical therapy, a lot of people think about pain. I'm going to go to my physical therapist to feel better. Yes, that is true, but pain, it's usually not a goal or not like a priority goal, even though for the patients are. But for a physical therapist, the range of movement, increased range of motion in the low back, like flexion, extension, lateral bending, rotation, and gaining the strength back, it's the biggest goal to get back to the activity of daily livings. It's very important to understand that, which I think practicing more, seeing patients more will actually help the new docs to understand that. As far as the prognosis of the patients, we do have short-term goals and long-term goals, which also helps the patient about their therapy expectations. Meaning, I'm going to set up a goal in 2 weeks from now that if you have only 30 degrees of lumbar flexion, but maybe in 2 weeks, I can help you to gain about 50 degrees of lumbar flexion. Therefore, you can bend over and tie your shoes. I know that might include pain. Pain might get better. Pain maybe not get better over time. But as far as range of motion, strength, and functional mobility is improved with the patients, those are the biggest goal for the physical therapist, and hopefully it's going to be reachable goals for the patients. We utilize outcome measures for every joint in the body. There are well studied. There are like questions about activity of daily living. I really suggest you guys look those up online and utilize those in the office. In insurance, really like those when you use outcome measures because it's filled by the patients. Outcome measures are given on a day of evaluations. Patients fill them up, and then it shows the percentage of ability or non-ability of the patients perform certain movements, such as squats, such as lunging, such as bending over, lifting heavy objects, twisting. It includes everything, depending what joint are you compromising. With today's topic is going to be low back. And then when we do progress notes in session 6, 7, or 8, or up to discharge, then we do outcome measures again. And then if patients getting better with their activity of the daily living, the scores will improve on their outcome measures. Therefore, when you're reevaluating your patient, the strength of the muscles and also the mobility of the joint in the low back will improve. When we put all that together, it shows objective increase or objective improvements of the patients, which if you want to bill insurance will be happy about seeing those improvement numbers. Patient will be happy eventually by visit 6 or 7. Patients' pain, it's more manageable. Patients can do more motion. In this podcast, I like to also expand on some approaches to low back pain. I just covered the evaluation step of low back pain, but also approaches to low back pain. Honestly, I get a lot of emails and text of how can I treat a low back? I can tell you a lot of things that you can utilize to treat the low back, but I feel like the most important part of helping someone with low back pain is truly evaluating them to understand what the issue is. Because in physical therapy, we always fix contributor factors, meaning if patient has tightness, if patient has weakness, or if patient has dysfunction in their mobility or dysfunction in performing certain activities, it's the job of a doctor of physical therapy to correct that. So a true evaluation will give you a lot of guidance to design the plan of care. I'm going to give you some examples. For a disc that we talked about it earlier, if the disc is acute, the job of the physical therapist is to manage pain for the couple days for the beginning of the therapy, which is the couple days after the injuries. Meaning you just have to make sure that the patient doesn't have much of a spasm, because the muscles around the spine and the muscles around the hip that actually gets very spastic. So one of the things that you can approach is assess them to see if those muscles are spastic, and then help the patients to relieve that spasm, which is going to help them with the low back pain. Why muscles get spastic after a disc herniation? To understand anatomy is we do have a lot of hip muscles attachments. The biggest one is iliopsoas, a tendon that attaches to the vertebrae of the spine and goes all the way down and attaches to the hip and attaches to the knee. So one of the job of these muscles is flexing the hip, but it's also when it becomes a spastic during the trauma, it will help to decrease further injuries, meaning the muscles get spastic to stabilize the spine. Therefore, the disc doesn't rupture or the disc doesn't get herniated. Yes, in some cases, the disc does get herniated, meaning that the spasm of the hip flexors wasn't enough for that injury. Therefore, patients had probably a severe trauma. Therefore, in that case, the disc has been ruptured. But on the disc bulge, the research shows that hip flexion tightness is usually a contributor of a low back pain. So assess that utilizing the special tests that we have in orthopedics, and then just release that muscle for the patients. What does a tight hip flexors do to the lumbar spine? Because of the anterior attachments of the hip flexors, it will push the spine into hyperlordosis. Hyperlordosis creates so much extension in the low back, therefore causes localized low back pain. So releasing of that, you can release it manually, or you can release it actively or passively by stretching it to offload the lumbar spine. Offloading the lumbar spine will help with the pain. But also, you have to find out what muscles are weak with the patients. Usually, the myotomal pattern, for example, if L5 and S1, there's a disc on L5 and S1, patient's going to have weakness on their ankle and down, like a big toe will be weak if patient has a disc on that area, meaning if the disc bulge is putting pressure on that nerve. So what we're going to do is we're going to make sure that patients utilizing those muscles to prevent atrophy later on with those patients. These are the two examples of a tightness and a weakness that we approach in the physical therapy office. We also have certain tests that we can assess the core integrity with patients with the disc in the low back, or in general just low back pain. A lot of health providers, I'm going to be just talking about my own field, which is physical therapy, discount the core. Understanding the core function into the lumbar spine or just throughout the spine is very crucial to plan of care, meaning don't discount that, test those muscles and make sure patient has good integrity or motor control utilizing their core. I almost use core exercises with all my low back patients because of the sedentary lifestyle that we have, because of so much seating that we do throughout the day these days, especially post-COVID. So almost everyone could benefit from core exercises. You can implement core exercises to plan of care to help those patients with a disc. And lastly, utilizing the lumbopelvic muscles, such as abductors and extensors of your hip, it's very crucial to create a very strong base so patients can actually have better offloading when they walking, when they do certain activities, so they have better absorptions of the force from the ground to their pelvis and minimize that coming up to their spine. Generally, these are the approaches of physical therapy to a disc in the low back or just general low back pain. We do have modalities that we utilize, such as dry needle therapy. It helps to increase blood flow in the muscles, and it helps to keep the muscles a little more relaxed, less spastic. You can utilize taping. You can utilize a suction cup therapy to relax muscles. Certain machines that we have in order to control the pain management. or also we do have a traction table that we can actually utilize to space out the disc. For example, when I talked about earlier, when you have degeneration of a disc, or if you have a disc bulge, kind of like this, in the lumbar spine, basically because of due to the pressure of the vertebrae together, the distraction table will help to create that neutrality in the vertebrae again. There's several things that we can do, but active and passive modalities are very crucial to help the patient. This was a short video about how to approach in a clinical setting, in the outpatient setting, with chronic or acute low back pain, and also some options to design your plan of care. Please write comments down here, subscribe my page, give me some feedback, let me know what else do you want to learn, and I share whatever I do with you in the office. Again, the purpose of these podcasts are here to learn, so teach me something. Have a great day.